afternoon, everyone. My name is Mikayla Dimitri, and I'm a technologist at the Royal Adelaide Hospital. Today, I'll be presenting a case study of optic nerve sheath meningioma and the role nuclear medicine had to play in diagnosing this patient's condition. The patient of my case study today is a 52-year-old female who has multiple sclerosis, an autoimmune disease of the central nervous system. MS interferes with nerve impulses within the brain, spinal cord, and optic nerves, and the most common symptom is vision problems. In January 2017, the patient started seeing wavy lines in her right eye, including some vision loss and mild headaches. 6 months later, she was diagnosed with right optic nerve sheath enhancement on MRI, suggested to be right optic perineuritis related to her MS. In August 2018, she began taking teriflunomide, an immunomodulatory drug for treatment of her MS. In June 2019, it was suggested that her optic perineuritis was not behaving as related to MS, but rather drug-induced. Her MS treatment was changed to 6-monthly injections of ocrelizumab, and she was followed up to see if this would reduce the inflammation around the optic nerve. Despite this, her symptoms of right-sided visual loss continued to worsen, and she was now getting sharp stabbing pains behind her right eye. On monitoring MRI scans, it was continuously suggested to be stable and chronic right optic perineuritis. As the diagnosis was not clear, with persistent disc swelling and more frequent and severe clinical symptoms, it was thought that she might have right optic nerve sheath meningioma, or ONSM. It was for this reason a 68 gallium dotatate PET-CT scan was requested. ONSM are benign neoplasms of the meninges surrounding the optic nerve, originating from the cap cells of the arachnoid. They typically grow around the optic nerve, as labelled by the red arrow in this image, meaning they can significantly compress the nerve and the vascular supply. They can invade the entire path of the optic nerve, from the optic canal posteriorly to the globe anteriorly. ONSM constitutes only 2% of all orbital tumours and only 1.7% of all meningiomas. They have a mean presentation age of 40 years and are more commonly diagnosed in females. Symptoms include visual loss, diminished colour perception, visual field defects, and dull headaches. Secondary ONSM is an extension of an intracranial meningioma growing into the orbit, labelled by the blue arrow in this image here. This patient's MRI showed enhancement with gadolinium contrast around the optic nerve in the right eye, which can be a sign of optic perineuritis. MRI appearances for ONSM can differ slightly from optic perineuritis, as in addition to enhancement, the appearance of a tram track pattern around the optic nerve can be seen. In retrospect, when it was discussed that perhaps this patient didn't have optic perineuritis, but rather ONSM, you can slightly see this tram track appearance on the axial slice circled in green. For these reasons, MRI may not provide sufficient information to differentiate ONSM from other optic tumours or inflammation, such as optic neuritis, highlighting the requirement for a more sensitive and specific, non-invasive diagnostic imaging tool. 68 gallium dotatate was synthesized by our radiochemists on site, and the patient was injected with 113 mbq intravenously. A 10-minute dynamic PET was acquired 41 minutes post-injection on a Siemens Biograph MCT flow PET scanner and fused with the accompanying low-dose CT. You can see on this cine here normal distribution of increased uptake of 68 gallium dotatate in the pituitary and salivary glands. There is abnormal uptake of dotatate in the right optic nerve, involving the length from the intraorbital component to the optic canal. You can also see another abnormal focus of uptake here in the frontal region of the skull. The appearances were reported for these two regions as consistent with ONSM. Fused images 1 and 2 show the increased uptake in the right optic nerve, localizing the ONSM with an SUV max of 5.9. Normal physiological uptake can be seen in the pituitary gland on image 2. Fused images 3 and 4 show the incidental focus of intracranial activity in the anterior aspect of the frontal region of the skull. This had an SUV max of 4.5 and was consistent with another intracranial meningioma. Meningioma cells strongly express somatostatin receptor subtype 2 or SSTR2, and it is this characteristic that forms the basis of using molecular imaging with somatostatin receptor ligands. 68 gallium dotatate, being a radiolabeled somatostatin analog, binds to the meningioma surface receptors to form a functional image, but not in other orbital lesions, such as perineural inflammation, leukemic infiltration, or optic nerve glioma. Due to the overexpression of SSTR2 in meningiomas, the use of these ligands in PET imaging provides strong tumor to background contrast, resulting in high sensitivity for the detection of meningioma. This case showed that gallium dotatate PET was vital in confirming the diagnosis of ONSM and differentiating the patient's condition from optic perineuritis, while avoiding invasive and risk-filled biopsy. In the setting where MRI was consistently suggesting the patient's worsening condition as chronic and stable perineuritis, nuclear medicine has guided this patient to the appropriate treatment path of potentially radiation therapy, rather than the use of steroids or the wait and watch method that can be used to treat and monitor perineuritis. As ONSM can cause blindness in the affected eye, nuclear medicine has been able to diagnose the true condition in this patient to minimize her symptoms with appropriate treatment. Thank you for your attention.